Hello, welcome to a summary board review type program aimed at covering the pathology of the small bowel. I hope that you'll find this useful as you prepare and augment your study of the surgical diseases of the small bowel that come across the pathologist's experience. Our objective is to highlight and recognize the diseases likely to be biopsied in the small bowel, and to provide some sort of meaningful and complete diagnostic information that may need to be accompany that. We'll also talk about some of the therapies that may result as a consequence of your particular diagnoses. So we'll start with some general considerations. First of all, let's just remember that the small bowel is a continuous organ, and that although we divide it into duodenum, jejunum, and ileum, based on some anatomical landmarks and some histologic changes, that it is a continuous process, and that there's no hard and fast feature that says one begins here and one stops there in terms of functionality. Of course, small bowel is characterized by the presence of villi, Paneth cells, and then these additional findings of lymphoid tissue and Brunner's glands tend to demarcate subset areas of the small bowel, like the ileum or the duodenum. As you approach the evaluation of the small bowel sample, I would strongly encourage you to have a systematic approach, so that each time you evaluate a small bowel biopsy, you preferentially run through your mental checklist of things to be considered and looked at, so that you don't immediately focus on the abnormality and miss a crucial clue or a second diagnosis. So I like to start from the inside and go out, begin with what's in the lumen. Are there parasites? Is there debris? Is there something there? What's in the epithelium? How does it look? Is it damaged? What's the lamina propria like? Is it normal size? Are the lacteals dilated? Is it expanded with lymphocytes, etc.? And then the vasculature. What is the vasculature showing you? Are there thromboses? Is there microthrombi? Are there lymphangitic spread neoplasia? What's going on in the muscularis mucosa? Is there a neoplasm there? Is there, evidence of myoenteric cells and so forth? And then finally, what's in the submucosa? As you think about what can happen here with each of these sites, you'll be more likely to correlate the clinical findings and not miss significant things. Of course, it's important to understand also the artifacts that can occur. I didn't have a good color picture, but I think you can see here that there's a sort of a nodular area here in the small bowel biopsy. And you would wonder, well, is this potentially histiocytes? Is this Whipple's disease? Could this be a nerve sheath neoplasm? Well, in reality, it's just some crushed Brunner's glands. But understanding these sorts of pitfalls and artifacts is critically important to correct interpretation. Things like repair is also important to understand and appreciate. Repair can lead to metaplasia, potentially of the gastric type, maybe even related to H. pylori, and can give a nodular appearance in the proximal duodenum. So is this then a gastric heterotopia? Well, usually that doesn't have reparative change. So seeing and putting those things together is sometimes important. In the ileum, however, if you see repair, well, that oftentimes is a marker for Crohn's disease. So those little caveats are important to consider. So let's talk about small bowel neoplasms. And they won't be quite as cute as this little fellow, I can promise you that. But they can be fun. Now, again, there are some caveats to remember. First off, the reactive changes we've talked about with a deep-seated tumor can be misleading. And so you need to remember that fact that Crohn's disease can be a mimic, or can be mimicking potentially a deeper neuroendocrine neoplasm or a GI stromal tumor or something. And also remember that sometimes your neuroendocrine tumors that are superficial can just look like inflammatory cells or clustered crypts and things of that sort. but that can be very serious because especially in the more distal ones, the neuroendocrine tumors are quite significant, and they're not like the indolent tumors we would often encounter in the stomach associated with atrophic gastritis. A few more little caveats to remember. Metastatic colon cancer can mimic a primary tumor. Pancreatic lesions can proliferate out onto the ampullary surface and look like a primary ampullary lesion. And then lacteals can be dilated, and you need to always scan those for isolated tumor cells, especially in somebody who has an unexplained intestinal illness. And the ampulla is particularly prone to reparative changes. If there's stone disease or a stent's been placed there, you need to dial back your dysplasia meter to make sure that you don't overdiagnose dysplasia or adenoma. With that said, adenomas are the most commonly seen lesion in the small bowel. They are seen usually in the proximal GI duodenum, and often are associated with familial polyposis. Well, that's partly because patients with familial polyposis are going to get upper endoscopy because of this presence. But you need to be aware of reparative changes and so forth. As elsewhere, we typically grade dysplasias with low and high grade categories. Here's a gross photos of these sorts of lesions that can be seen in the ampullary area, sort of fungating polypoid lesions, rolled edges, and undulations of the surface. Typically, most commonly, they're found to have sort of intestinal type dysplasia, intestinal type atypia. And you can see some here involving the ampulla, higher magnification here with the nice elongated pencil-shaped nuclei. However, in addition to intestinal type metaplasia, we can also see pancreatico-biliary type epithelium. This is the sort of epithelium that we would associate with pancreatic intraepithelial neoplasia or intraductal papillary mucinous neoplasias with low-grade degrees of dysplasia. And you can see it's got more clear cytoplasm, maybe a little bit of stratification and atypia of the nuclei, but this can be quite variable from just elongated enlarged cells with minimal basal atypia to even high degrees of carcinoma in situ. Now I mentioned we grade dysplasias, and if you were to pick which is which, I'm sure that all of you with experience would quickly choose the right-hand image as representing high-grade dysplasia. Well, why? Why do we do that? Well, it looks less like normal epithelium than the stuff that's here on the left. Here we just see a little bit of stratification, a little bit of crowding, but the nuclei are still basal, minimally enlarged, and we still have, some pan-S cells and some mucin remaining in the epithelium. So it does mimic more closely the normal type of intestinal epithelium. Here we've lost the mucin. The nuclei have begun to round up, become more rounded. They're more crowded. The architecture begins to change, becomes more solid and convoluted, maybe even cribriform. And we may get other areas where we see more cytoplasm, suggesting even the possibility of early invasion. A lesion that may not have this intestinal type metaplasia or intestinal type of dysplasia is pyloric gland adenoma. Here we can see on the left a relatively bland appearance, pink, pale cytoplasm that even can mimic Brunner's gland hyperplasia. But these do have an association with carcinoma, and although they're more commonly seen in the stomach, the proximal duodenum certainly is also a location to be concerned with. We'll move on to hamartomas of the small bowel, and I would alert you to some companion videos that we've done recently on Peutz Jegher's polyps and juvenile polyposis, both worth a moment or two of your time. These, as I would emphasize, are hamartomas, and by that, typically we would expect to see normal mucosal elements involving these things with other components like stroma and so forth. With the Peutz Jegher's polyps, the key difference is the arborizing smooth muscle. whereas juvenile polyposis syndrome tends to have an edematous, lamina propria, and cystically dilated glands. It may have some ulceration and granulation tissue-like stroma as well. These can occur just about anywhere in the GI tract, and when they occur, they are typically comprised of the normal mucosal elements that you would expect for that site. Dysplasia can occur in all of them. It's not common, but you need to consider that. Specific mutations, here's the board question. Stack 11, most commonly associated with Peutz Jegher's polyps, SMAD4 and BMPR1A, associated with juvenile polyposis, and of course P10 associated with P10 hamartomas and tumor syndrome. These are even more rare than the others, and can appear in a variety of different polyp types, and so therefore is difficult to recognize de novo. So just touching on Peutz Jegher's polyps, as I've already indicated, these are hamartomas with the epithelium native to that portion of the duodenum or portion of the bowel where they occur. Here's a nice gross photograph. They tend to be fairly large polyps by the time they're detected, often have a stalk, and that's because they will have this arborizing smooth muscle that grows out into the fronds of the polyp. Each of these lobules will have a central core of smooth muscle. So arborizing, that means tree-like. So think branches of the tree when you think of Peutz Jegher's polyps. Juvenile polyps, in contrast, again, the same kind of mucosa that you find in that organ, but a lamina propria that's more edematous and mixed, some loose myxoid tissue, maybe some fibrous tissue, generally very little or no smooth muscle, and characteristic deep glandular dilatation. The lymphoid component here is kind of hit or miss. Sometimes you will have that, sometimes not. And as we mentioned, be sure to look for areas of potential dysplasia in these lesions manifest as you would see dysplasia elsewhere. Well, let's move on and talk about neuroendocrine tumors in the small bowel. These lesions come in a variety of flavors. The proximal ones, the foregut ones, as we've indicated in the stomach, and even in the duodenum and pancreas, can oftentimes be sort of gastrinomas, the source of Zollinger-Ellison syndrome. The remainder are largely somatostainoma, and we've again done a companion video with one of these cases nicely illustrated. Rarely you'll see the carcinoid syndrome with these lesions of the foregut, but the more poorly differentiated tumors can also occur, and usually those are in older patients. Small cell carcinoma, neuroendocrine carcinomas can occur but are uncommon. As we've mentioned, the periampullary somatostainoma has a characteristic appearance with a gland-forming appearance or pseudo-gland-forming appearance, a PAS-positive secretion, and then usually a good number of Samoma bodies. The literature says 60%, but maybe because they've done immunohistochemical staining for somatostatin in more cases than we have. Diarrhea, glucose intolerance, and cholelithiasis is the classic triad associated with this syndrome, and helps to confirm the diagnosis in the presence of a proximal duodenal neuroendocrine tumor. Looking a little bit more distal tumors, these are usually derived from enterochromatin cells, and they will be producing serotonin. Now, we associate serotonin with the carcinoid syndrome, but that's really only seen in a small percentage, and conventionally that's thought that those are the patients who have metastasized to the liver, and you're bypassing the hepatic metabolism of serotonin. Some have been found in association with carcinomas at another site, and they can be multifocal, and sometimes we've seen resections like this, but these are actually, as they've been studied, found to be most commonly intramucosal metastases. Here's an example, image of several mucosal yellowish tumors. And X chromosome inactivation tends to show that these are, in fact, identical genetically, representing metastatic lesions. Typically be positive for both synaptochromo and CDX2 if you need to do neuroendocrine markers. In terms of staging, reporting these lesions, there are up-to-date protocols for neuroendocrine tumors in the GI tract, and those are distinct from other sites. Key features as expected: site, size, and grade, well differentiated based on mitotic count, poorly differentiated based on morphology, margin status, lymphovascular invasion, lymph node status, and so forth. And site is quite important in terms of predicting behavior. Just to give you an example here, behavior and characteristics can be different, obviously, in terms of staining in different sites. You see here with synaptophysin, quite a difference between foregut lesions and mid and hindgut tumors. Other markers may also be different, and associated syndrome that you would expect with carcinoid up to 40% in the checklist data. In terms of margins, one of the things that people sometimes encounter as a problem is how do we define the circumferential or radial margin? If you check the notes for the checklist, the CAP checklist, as I recommend you do frequently, this represents the margins closest to the deepest penetration of the tumor, and it's a margin that is created either surgically by blunt or sharp dissection of the tumor or the tissue from the retroperitoneal or subperitoneal tissues. And that distance from the tumor to that radial margin should be reported as the radial margin difference. What's negative? Well, more than 1 millimeter, call it negative. If it's within 1 millimeter, that's going to be called positive or R1 resection. This is in contrast to some other organs where you need to see tumor on ink. In the bowel here, you do not report it that way. All right, another tumor that sort of bridges the gap between neuroendocrine tumors, but is still in that category, is gangliocytic paraganglioma. This is a quite site-specific lesion occurring almost exclusively near the ampulla in the duodenum, and it tends to be middle-aged males. It does have an association with neurofibromatosis and may cause bleeding or bile duct obstruction in terms of presentation. It will stain with non-specific, or excuse me, with neuron-specific enolase neurofilament as well as synaptophysin, and then S100 can be useful to define the sustentacular cells. Not usually hormonally active. Its morphology, however, can be a little confusing and variable. You can have a predominantly fibrous appearance, maybe a fibrous appearance with a few ganglion-like cells. And then you can also see sort of a packeted and nested appearance as you see here on the right. Higher magnification, again, the cells will appear somewhat neuroendocrine-like, maybe rounded in nests as you see here, round nuclei, somewhat oval, and a granular, maybe amphiphilic type cytoplasm with maybe a few ganglion-like cells. Sometimes the cytoplasm is a little bit more grayish, and rosette type structures can be seen in this lesion as well. So rather heteromorphous appearance to this tumor, and certainly something that you should be on the alert for based on the location. You'd pass by that diagnosis in terms of something further down the GI tract, but in the periampullary area, this is one of the interesting tumors we can sometimes encounter. Well, let's talk about carcinoma in the small bowel. Fortunately, there's not a lot to say here because these are uncommon. These usually follow the same adenoma carcinoma sequence of events that you'd see in the colon. And they're perhaps more prevalent or frequently associated with the polyposis syndromes, maybe Peutz-Jeghers or juvenile polyposis, as well as patients who may have an inflammatory background like Crohn's disease or diversion, enteritis, and so forth. Celiac disease, potentially even as an inflammatory precursor for these tumors. The dysplasia sequence, of course, as we indicated, low-grade dysplasia here with elongated nuclei stratified, rounding up into high-grade dysplasia, and then a loss of mucin, more complex architecture, higher NC ratio, and then subsequent development of invasive neoplasia. So there is an entity that is not commonly encountered, but can be seen, which is called ileitis cystica profunda. We have comparable lesions in the stomach. And the distinction between this and invasive carcinoma is largely based on the sort of distinction we might use with adenomyosis in the endometrium and myometrium. We have a lamina propria. We have a surrounding periglandular stroma that is distinct from the type of usual tumor response that you would like to see in frank carcinoma. And so being on the alert for that pitfall is perhaps worth consideration. In small bowel carcinomas, like other locations, KRAS mutations are fairly frequent. P53 mutations and APC mutations can be seen, but the beta-catenin pathway is very commonly seen. Mismatched repair defects, both germline and sporadic, can be found in a fairly good percentage of these patients. And SMAD4 also can be found as a molecular alteration in many of these small bowel tumors as well. So more frequently seen than perhaps primary carcinomas are metastatic carcinomas. And in terms of evaluating that, I think you want to think about a couple of considerations. First of all, is this a single site lesion or do we have multiple sites? If it's multiple, much more likely to be metastasis. Is it bottom heavy? In other words, is there more in the lamina propria and muscularis propria than there is in the mucosa? Well, that's more likely to be metastatic. Do we have a precursor lesion? Do we have an adenoma? Do we have in situ tumor? Do we have ulceration or not? And if we don't have a precursor lesion or ulceration, again, less likely to be primary neoplasia. Other things that, or things that can most commonly mimic primary carcinomas, as we've mentioned, metastatic colorectal carcinoma. Melanoma on occasion can appear as a undifferentiated carcinoma. Breast cancer, lobular carcinomas in particular, can appear as a diffuse type carcinoma. Some gynecologic cancers, serous carcinoma, high grade, prone to gastrointestinal invasion and can mimic a primary tumor. And not uncommonly, endometriosis can mimic small bowel carcinoma. Reporting, again, we have a protocol that's pertinent and specific to the small intestine. I'd urge you to check the CAP website for the most current version. They tend to be updated annually, and this slide was put together a while back. The specimen type, size, grade, depth of invasion, margin status, presence or absence of lymphovascular invasion, clinical backdrop, things of that sort, staging data, depth of invasion, of course, indicating T stage, end stage based on number of lymph nodes, and so forth. Just to sort of expound a little bit more fully about these CAP protocols, although they may be familiar to many of you, these checklists have been developed for many sites as a means of standardizing reportings and making sure that we have inclusive data for as many of the important criteria. By using a synoptic list or format, they promote standardization and completeness of report. And that's been demonstrated in study after study. In some locations, regulatory requirements may actually require the use of these checklists to ensure high-quality patient care. If you're an accredited laboratory by the CAP, well, you've got to use these as well for a demonstrated majority of your patients. Well, let's talk about lymphomas involving the small bowel after we look at this cute little boy here. These lesions, most common of which is maltoma, but it's less frequently seen in the small bowel than in the stomach. Usually these are older patients. They have exophytic mass lesion, but we don't see the lymphoepithelial lesions quite as commonly as we would in the stomach. We may see Dutcher body or Russell bodies not infrequently, and sometimes they're mixed with a large cell component as well. Another important lymphoproliferative disease to involve the small bowel is immunoproliferative small intestinal disease. This includes heavy chain disease, Mediterranean lymphoma, small lymphocytic intestinal lymphoma. These lesions can be somewhat geographic specific, obviously by virtue of the name here, and the category of growth in terms of staging. So there's a diffuse pattern that is termed stage A, a nodular growth pattern that is categorized as stage B, and a high grade or grade C, which has a much more high grade morphologic appearance. Clearly, the treatment is going to vary by stage, and these, again, are a subset of the mucosa-associated lymphoproliferative disorders. Mantle cell lymphoma can occur in the small bowel as well. It tends to be older adults and tends to have both nodal and extranodal involvement. Usually, if the small bowel is involved, then you'll have colon disease as well. And so maybe you can get to the diagnostic tissue more easily through the colon than by going into the small bowel. Sometimes this lesion presents as lymphomatoid polyposis. And these lesions, of course, characteristically typically co-express CD20, CD5, as well as cyclin D1. Burkitt's lymphoma, particularly in some locations, is endemic and may involve the small bowel, particularly the distal small bowel. Because of the EBV association, can be seen in young patients and involve the ileum. These lesions are CD20 and CD10 positive and have an enormously high proliferation rate, which is usually diagnostic. T-cell lymphomas also occur in the small bowel, and these are often associated with gluten-sensitive enteropathy, but not infrequently in patients who have not been particularly observant of their gluten-free diet. These tend to be CD3 positive and negative with most other markers, of course, 4, 8, 7, 56, and they have a poor prognosis. Because these patients also have malabsorption due to their gluten-sensitive enteropathy, they do not typically have a high degree of a robust health at the time of presentation. So moving on to mesenchymal tumors, the most frequently seen, as mentioned, is the GIST. And as we would like to point out, these tumors in the small bowel have a more aggressive behavior than they do in the stomach. However, the case numbers on which we can base these predictions are fairly limited. The gangliocytic paraganglioma, we've already talked about that mesenchymal neoplasm. And this is just to illustrate this from the risk stratification guidelines. Notice that for the same size and mitotic rate, here under 5 centimeters, we have very different categories of prognosis. These lesions of the duodenum and jejunum are all very high risk of recurrence at really very high rates with either large size or even small size with high mitotic rates. Well, children and GI disorders is a topic I'd like to cover in more detail with one of my pediatric pathology colleagues at a future point, but I will just go through that here briefly. Some considerations are important based on pattern, and this little chart here derived from a notable textbook of GI pathology provides some indication of the kinds of considerations in terms of congenital deficiencies, malabsorptive syndromes, and so forth that may be operative with different patterns. So with a normal pattern, there's a variety of malabsorptive or deficiency syndromes that can have very normal histology. With mild inflammatory disease, celiac disease can be, or autoimmune enteropathy, variable atrophy. You can have bacterial overgrowth, such as you might see with tropical sprue, protein intolerances, and so forth. And then there are the more specific lesions where you say have fat-filled enterocytes that suggest A-beta lipoproteinemia, ectatic lymphatics, dense mucus, epithelial abnormalities such as in microvillus inclusion disease, eosinophil predominance, and so forth. So we'll just sort of cruise briefly through some of the high points here. So A-beta lipoproteinemia has this nice vacuolar change to the epithelium, indicative of some lipid and membrane defect that also corresponds to the blood smear, peripheral blood smear formations of these echinocytes and maybe a few schistocytes in the peripheral smear. Enterocyte lipid vacuolization, another disorder, can have fairly normal architecture, but can have a variety of different diseases. We've just showed you the A-beta lipoproteinemia, but hypo-beta lipoproteinemia, chylomicron retention disease, protein calorie malnutrition, gluten-sensitive enteropathy, diabetes, all can have similar morphologic features. Another specific disorder in terms of epithelium is what's been termed microvillus inclusion disease. This is a genetic autosomal recessive disorder resulting in refractory diarrhea that oftentimes presents at a very young age. And the specific gene marker has been worked out. This is something that requires parental nutrition or potentially even transplant. And as you can see here, we've got very marked villus atrophy. So not everything that is sprue is, not everything that's atrophic is going to be sprue, particularly in the pediatric age group. And here's the nice example on the left, normal small bowel mucosa stained with a PAS stain. And here's microvillus inclusion disease. You see these abnormal villus inclusions along the brush border, whereas typically that's more linear form here in the normal structure. So a nice illustration side by side of that disorder. Okay. Next, other things that can give you villus atrophy: celiac disease, we've mentioned, autoimmune disease, trichohepatic enteric syndrome. I'm still waiting to see my first case of that. Tufting enteropathy, enteroendocrine cell dysgenesis. These are textbook cases and pediatric center type of diagnoses, not usually encountered in routine surgical pathology. Autoimmune enteropathy perhaps does often present early in life with diarrhea. These patients may also have dermatitis and some endocrine disorder, unresponsive to gluten restriction. Does have autoantibodies, but we don't know what the antigen is. So here's the direct immunofluorescence showing a marked staining with anti-IgG, And these patients typically require some sort of immunosuppressive therapy to thrive. Differential diagnosis, these lesions, I won't spend a great deal of time on this, but if you are interested, can refer you to the references afterwards. So let's just touch then upon some of the infectious disorders in the small bowel, make people a little bit happier because these are more treatable. Mycobacteria, most commonly Mycobacterium avium, particularly if the patient is immunocompromised. These can be a significant infection and require treatment. Pain, fever, weight loss, malabsorption, and relatively minimal inflammatory response, particularly if they're immunosuppressed. In fact, the very first AIDS patients with these disorder had virtually no inflammatory response, no granulomatous response, but had multiple organisms, high organism burden. And here's a nice example. Here we see some macrophages and so forth, and here a heavy organism burden within these macrophages. So not terribly pronounced inflammatory response. Another fun infectious disorder to encounter in the small bowel is strongyloides, where the small bowel plays a critical role in the life cycle. As you can see here from this diagram, the larvae are expelled into the environment, and they can either proceed to go through a sexual cycle or directly penetrate the skin as the filiform larvae migrate to the lungs, swallowed into the bowel, and then become active and pass through the cycle again. What becomes critical is if you get autoinfection, if you get the cycle going through here, they can become potentially invasive. And here's a nice image of what these look like in the small bowel. Lots of little larvae and parasite bodies structured in various coiled degrees within the crypts and sometimes within the epithelium. It's when these patients are treated with immunosuppressives that then these filiform larvae get hyperactive and become invasive. Whipple's disease, caused by the actinomycete Trophorema whippleyi, is another important disease to be aware of and to have a sensitivity for. This is most commonly male, white males, middle-aged, and they present with diarrhea and fever, some weight loss, malabsorption, sort of GI tract symptoms. But they may also have arthralgias, cardiac conditions, even some central nervous system symptoms. And this is what makes this a challenging disease, because it's this disseminated symptomatology that makes this disorder a challenge both for the patient and for the diagnostician involved, because these can be variable. Sometimes these patients may be seen as quacks or see multiple doctors before someone finally hits upon the diagnosis. And of course, it's eminently treatable, but this chronic relapsing course that can be there is important if we don't get full and proper therapy. Just to review kind of the life cycle here, these organisms colonize the GI tract, come in from the lumen, and then they're taken up by macrophages, which engulf them. That leads to cytokines being released and so forth, recruiting other cells into the area, macrophages and so forth. And then ultimately there's apoptosis of these macrophages, which releases the microorganisms which have not been killed within the lysosomes into just potential spread where they've been taken up by the dendritic cells, and some have become tolerant. So that leads to your symptoms in the CNS and lymph nodes and other sites in the body. So that's the challenge. Diagnosis is usually made by small bowel biopsy and seeing these prominent pale histiocytes within the lamina propria. Typically, these will stain with PAS stain, but you can also find a specific immunohistochemical reaction for this microorganism and potentially do electron microscopy. One caveat here is that because there are cell debris products in these histiocytes, they can sometimes stain positively for pancytokeratins or other cytokeratins, potentially leading to a misdiagnosis of signet ring cell or diffuse type carcinomas. Other parasites to be aware of, certainly in the small bowel, Giardia is probably the most prevalent parasitic disorder. And it's easily missed if you're not thinking lumen, enterocyte, lamina propria, vessels, muscularis, etc. If you're just focusing on the villi and so forth and not paying attention to what's in the lumen, you will miss these. However, when you find them, it gives you a great thrill. Celiac disease we'll touch on here. It's not an infectious disease, but it represents an autoimmune response to gluten, which is present in a variety of grains, grains that are most commonly used in the Northern European and Western diets, less commonly used in Asian and East Asian diets. It does have some extraenteric manifestations, skin disease, joints, etc. And there is in the literature the Marsh classification, which we'll briefly cover, but it's not terribly clinically useful in terms of day-to-day practice. There is an HLA type association and more perhaps indicating susceptibility. These patients will have anti-gliadin antibodies, and just to illustrate the geographic variation. You hardly ever find it in Myanmar, but you'll find it often in Finland. Typical symptoms associated with celiac disease are very helpful for the diagnosis, and it's not a histologic diagnosis. The histology can suggest the diagnosis and be consistent with the diagnosis, but really positive serum antibody, anti-IgA, anti-gliadin antibodies, plus or minus the appropriate HLA type, and response to the gluten-free diet are all very helpful in making the diagnosis. In terms of staging, here's the Marsh classification, a 1 through 4, or 0 through 4 staging classification, and I'll just illustrate what these may look like. Essentially, we're talking about the degree of atrophy in the villi, and we're talking about how much of an inflammatory infiltrate you're going to see. Prominent intraepithelial lymphocytes at Marsh 1, but no architectural change. Some enlargement of the crypts with stage 2, and then you begin to see atrophy with stages 3 and 4. Here's a wonderful scanning gross microscopy photo showing normal villus structure here, and then here the altered vasculature and blunted villus architecture in celiac disease. So conceivably, this is also what magnifying endoscopes could provide. Here's an example of the earliest clinical lesion, intraepithelial lymphocytosis, as demonstrated with CD3 stain, Marsh stage 1. With a Marsh expanded lesion, we may see the beginning of blunting. Here you see a little shortening of the villus, a sort of a plateau surface, and still intraepithelial lymphocytes. And if you were to have gluten-sensitive responsive enteropathy here, that would be appropriate. But certainly in this sort of a biopsy, we would recommend antibody testing as well. Moderate mucosal lesions, a little bit more blunting, more cellularity, more lymphocytes, expansion of the basal material, and then finally, the most severe type lesion, total atrophy of the villi, flat surface, and still have epithelial damage and increased intraepithelial cells, but But this, of course, can have differential with other considerations, which we've touched on earlier. But I'll just pull up this little chart here to show you other things that need to be considered in the differential diagnosis. This from Dr. Odes and Goldblum's nice textbook on GI pathology. Things that can give you blunting, common immunodeficiency, microvillus inclusion disease, autoimmune, tropical sprue, which in some circumstances is similar to refractory sprue, bacterial overgrowth, which may be related, radiation, chemotherapy, and eosinophilic gastroenteritis and Crohn's disease can also occasionally lead to blunting. Several things can be associated with intraepithelial lymphocytosis, lymphocytic enteropathy, autoimmune, tropical sprue, and helicobacter, viral gastritis, and so forth. Protein intolerance can also be a problem and lead to biopsy of the small bowel. These patients may have vomiting or diarrhea. Usually, of course, these are pediatric patients. And oftentimes you'll have increased mucosal eosinophils with variable amounts of blunting that may resemble gluten-sensitive enteropathy. Tropical sprue, we just mentioned in the differential. Uncertain etiology, though we suspect that there's some sort of an initiating infection that's at the base cause of this. It leads to some degree of bacterial overgrowth, and that may be a toxigenic strain that decreases peristalsis, prolongs transit times, leads to malabsorption, and therefore may even lead to vitamin deficiencies. The distribution of this disorder is quite interesting. We see it centers around the Caribbean basin in the Western Hemisphere, northern South America, not involving the tropical zones of the Western Pacific Rim, other than a small area here in Central America. A couple of hot spots in the Mediterranean, and then a broad distribution from the Persian Gulf on through South Asia, Southeast Asia, Indonesia, Malaysia, Philippines, East Asia, China, Taiwan, and even some areas of Japan. So that's a very interesting distribution. No involvement in West Africa, quite instructive and interesting to try to figure this one out. It does respond to antibiotic treatment, sort of going along with the bacterial overgrowth theory. Here's a nice example of what it can look like. We see just lots and lots and lots and lots of lymphocytes here in this intraepithelial compartment, not too much increased elsewhere, and variable degrees of blunting, as we've indicated. If you like haiku, here's a little haiku to help you remember this. Oh, tropical sprue, villus crypts with lymphocytes, gluten not to blame. So there we go. On to the next component of this, bacterial overgrowth syndrome. Again, as we've mentioned, this is not commonly seen, blind loop syndrome, sorts of things, usually post-surgical, associated with steatorrhea, malabsorption, vitamin deficiencies, and secondary effects. And this is usually because we've got anaerobic bacterial growth. So the microbiome, which is becoming increasingly more studied and looked at, is disturbed in these architectural changes, and that not surprisingly leads to disease. Eosinophilic gastroenteritis can involve any level of the GI tract, from the esophagus onto the distal colon, but it's really only when it involves the mucosa that we tend to see it, although there are mural, intramuscular, and serosal variants that may be detected in some settings. It's really not clear what the etiology is, although one would surmise that there's some sort of an ingested allergen, particularly in the mucosal varieties. That's certainly seen in eosinophilic esophagitis, sometimes in eosinophilic gastroenteritis, gastritis. Complicated name, acrodermatitis enteropathica. This is a genetic disorder that has manifestations within the skin, the dermatitis component, and within the bowel, and also within the CNS. Presents in childhood with the decreased mental function. Patients develop zinc deficiency due to abnormal absorption and not having the right enzymes, and may have blunting as well, overlap. Coming back to something more common in the inflammatory disease is Crohn's disease. This also has some genetic association. The ileum is a very significant site of involvement, but we can see this obviously at other levels on up to the stomach and even the oral cavities on occasion. Typically, this is a fissuring ulceration type of disorder. May have a bit of a cobblestone appearance, furrowing of the mucosa, as we'd see in the colon, and the development of fistula tracts because of the pancolitis nature, where it involves, the inflammation involves the adventitia as well. Here's an example of one of these fissuring ulcerations in Crohn's disease, a deep crack extending into the submucosa that ultimately can extend all the way through the wall. Occasionally, you'll find loose granulomas in the mucosa in these patients. Lymph node granulomas are also seen in a lesser degree, and that is helpful in the diagnosis, but it's really the distribution of the disease and the overall pattern of the inflammation. Granulomas are not required. Well, since we see inflammation in the terminal ileum and Crohn's disease is something we're going to think about, there are a few other things that should probably be excluded when you see it. So one is nonsteroidal drug injury. This can produce ulcerations, variable surface inflammation, with or without pyloric metaplasia in this area. Backwash ileitis, typically associated with some degree of colonic inflammation in ulcerative colitis, can occur. It's rare, and again, you can occasionally get pyloric metaplasia. Infection with Yersinia also can be associated with ulceration and active inflammatory disease in the terminal ileum and associated lymph nodes. Behçet's disease, very rare. Oral and genital ulcers, uveitis, vasculitis, and ileitis. And then, of course, vasculitis and ischemic changes with so-called withering crypts, hyalinization, a characteristic of ischemic changes. This is not usually confused with Crohn's disease. So we biopsy the terminal ileum very commonly in Crohn's disease. We're looking for evidence of blunting or active inflammation. We don't see blunting very often, but we do see distortion. We can see small aphthous ulcerations and intraepithelial neutrophils, which I think you can see a few of here, and variable numbers of granulomas on occasion. In contrast, backwash ileitis typically does not show much in terms of architectural distortion. You may have little crypt abscesses, but not very much chronic inflammation, and it's typically within the first 5 centimeters from the ileocecal valve. Patients have undergone diversion procedures. They can have creation of ileoureteral pouches and so forth, or ileoanal anastomoses. These patients can get variable inflammatory processes that look for all the world like inflammatory bowel disease. And of course, often the differential includes recurrent inflammatory bowel disease. So just a few other entities to end with. IgA deficiency is due to the mutation in the TNFR-SF1-3b gene in some cases, at least. We do see increased intraluminal infections such as Giardia and strongyloides. These patients, as we mentioned, have an association with Hamartomas. And there are also other inflammatory processes that may be more frequently seen in these patients, like food allergies, celiac disease, and so forth. It's most common in those of Northern European ancestry and does have some association with diabetes. It's not a specific etiology, and so the clinical presentation and protein electrophoresis or quantitation would be required for diagnosis. B12 deficiency, which we've mentioned can accompany things like tropical sprue or other malabsorptive syndromes, can, in the situation that you have a severe form, lead to the same kind of cytologic abnormalities that we associate with B12 deficiency in the bone marrow, specifically macrocytosis, and here you can see a nice enterocyte with a macronucleus, and some degree of atypia in these lesions. So seeing that sort of disorder and a patient with chronic diarrhea or some sort of malabsorptive syndrome, it's not unthought of to consider the diagnosis of B12 deficiency. Drug injury is very common in the small bowel. Most common agents are nonsteroidals. Those are very commonly taken. But there's a growing list of immunomodulatory drugs, ipilimumab, many of these checkpoint inhibitors, as well as some chemotherapy agents can produce various abnormalities in the small bowel, and those deserve consideration. The patterns can be quite variable, but checking the medication list and possible complications is important in those settings. Other things, K-exalate can produce ulcerations and even perforation, colchicine, abnormal atypical mitotic figures, iron sulfate, crystalline enteropathy sorts of changes, and of course, antibiotics and so forth. NSAIDs, as I mentioned here, as an example of a type of injury, sort of a blunting, fibrosing disorder, a little bit of epithelial reactive atypia, collagenous changes. This can even lead to the formation of sort of webs as the scarring proceeds, leading to potentially problems within the lumen of the small bowel. Now, those don't usually cause obstruction because the stool is still liquid at that stage, but it certainly can alter motility and create some other symptoms. Ischemic disease can occur in the small bowel. It's uncommon, but if a patient has had a significant hypotensive episode, the watershed areas can become ischemic. Graft versus host disease can affect the small bowel in patients, particularly in that first 30 to 60 days post-transplant. Amyloid, Crohn's disease, Behçet's we've talked about, and other things like heterotopia, Meckel's diverticulum. Those are disorders to bear in mind that can occur here. So the list is very long. So here's a case of thrombotic disease. Here you see the thrombus and secondary ischemia. Here's what we call the withering gland appearance, where these glands and the epithelial cells become very small and the cells lose their cytoplasm. And then there's this sort of fraying off of the surface with a sort of pseudo-inflammatory infiltrate and necrotic debris. Very characteristic of ischemic change in the small bowel as elsewhere in the intestine. Number of diseases could be involved with these vascular ischemic states. Of course, occlusive disease, thrombotic, embolic, low flow, mechanical problems, herniation, volvulus, hypercoagulable states, DIC, congenital factor disorders, infections such as neonatal necrotizing disease, clostridial infection, and various other things like vasculitis, radiation injury, some drugs, even contraceptives, rarely. Intestinal lymphangiectasia, another congenital disorder most commonly that can lead to protein loss. Here's the characteristic morphology. Not easy to miss that one with these big dilated spaces. But there are also some secondary types that can be related to neoplasia or Crohn's disease, even prior transplantation. Things that disrupt the lymphatic drainage system can lead to this disorder. And with that, we have come to the ileocecal valve. So thank you for sticking with me through this. I'd love to hear your questions, comments, and of course, if you like this, please share it. Welcome your feedback. I'd love to hear from your comments below, and hope that you'll join us for future episodes and installments on this journey of providing some video evidence of gastrointestinal pathology and instruction as you seek to learn the same.